Hello and welcome to the Cincinnati Heart Failure Lecture Series. This is part of the basics. In this lecture, we'll cover congestive heart failure, part 1. My name is Mahir Poriyahi and I'll be guiding you through this lecture. We will discuss definition, epidemiology, classification, etiology, history and exam, and imaging. What is heart failure? It's a complex clinical syndrome that results from any structural or functional impairment of ventricular filling or ejection of blood. What are the manifestations? The manifestations relate to the fluid congestion, which can be seen with pulmonary and/or systemic symptoms. Treatment goals focus on preventing progression of disease and reducing disease-related morbidity and mortality. Why is heart failure important? Heart failure accounts for 45% of cardiovascular deaths in the US. Approximately 6.7 million Americans over the age of 20 have heart failure, and the lifetime risk of heart failure has increased to 24%, or approximately 1 in 4 individuals, as opposed to what it used to be previously, which was 1 in 5. With this, we come to the universal definition and classification of heart failure. This is a little bit older at this point. However, this brought the American College of Cardiology, the American Heart Association, and the Heart Failure Society of America together with some of its international partners to come up with definitions and risk stratifications. The definitions we've already spoken of. It further focused on the ACC staging, as we all are aware of, which is stage A is at-risk population, patients with risk of heart failure without current or prior signs and symptoms, and without structural cardiac changes or elevated biomarkers. Stage B, which is pre-heart failure, which are patients without signs and symptoms, but with structural heart disease, abnormal cardiac functions, or elevated natriuretic peptides or cardiac troponin levels. Stage C, which are patients with signs and symptoms. And stage D, which are the advanced heart failure, or patients with refractory intolerant heart failure, which might benefit from advanced therapies such as transplant or mechanical circulatory support and or palliation. It further divided heart failure by ejection fraction, less than 40% being called reduced, 41 to 49 being called mildly reduced, and above 50 being preserved. Heart failure with improved EF is an ejection fraction of less than 40% with 10-point increase from baseline and a second measurement of EF above 40%. New classification of heart failure according to EF. Terminology and how we discuss heart failure is critical. We should look at heart failure the same way we look at cancer. So terminology such as recovered EF has been pushed away, and now we have persistent or in remission. Here you can look at median survival in years with the different types of heart failure and at different age groups as compared to an average life expectancy within the US. And as you can see, all the different subtypes of heart failure critically change your overall life expectancy. This is a slightly older paper that looks at the subtypes of heart failure and the overall mortality. They use an ordered terminology for heart failure with mildly reduced ejection fraction by calling it HFBEF. However, what's important about this graph is the overall cumulative incidence and 5-year mortality with all the subtypes of heart failure and how they're all practically very similar. This slide puts everything together of what we've discussed. So the at-risk heart failure, the stage A, patients with high blood pressure, atherosclerotic disease, diabetes, obesity, metabolic syndrome, or patients using cardiotoxins or family histories. It's important for us to change lifestyle, prevent vascular coronary disease, and when appropriate, prescribe medications such as ACE inhibitors or ARBs or statins where it relates. In the stage B population, again, patients with previous MI or myocardial infarction, valvular disease who are asymptomatic otherwise, our goal is prevent heart failure symptoms. Our goal is to prevent cardiac remodeling. Where appropriate, ACE or ARB inhibitors, beta blockers, and depending on subtype of disease, possibility of revascularization, valvular-related operations, or defibrillators. Stage C is our bread and butter heart failure that we think of. So patients with symptoms, clinical symptoms, and with something that affects the relaxation or ejection of blood. We start them on guideline-determined medical therapy, which we'll go over, possibility of other drugs, also try to limit their comorbid conditions and treat them aggressively, plus or minus CRT and ICD. Stage D are patients that hopefully by this time are seeing heart failure expert with a focus on what are the necessary steps to deal with end-stage heart failure, whether that is the mechanical circulatory support device, whether that's transplantation or palliation. We will not go so in depth into this slide. However, this is kind of putting the Lewis-Wiggers diagram of a cardiac cycle and subdividing the cardiac cycle. We'll discuss this further at a later lecture. So what's etiology of heart failure? 68.5% ischemic disease. Hypertension makes the other 7.2%. And then a mix of a lot of things, from toxic metabolites to autoimmune diseases to amyloid. History exam is essential. Relevant family history, such as genetically related cardiomyopathies, coronary artery disease, hyperlipidemia syndromes, are important factors to be aware of. Other risk factors, such as toxic metabolites or toxic use, plus other disease processes, such as carpal tunnel or other autoimmune diseases. Serial weight can be helpful to give us an idea of the fluid weight. And then JVP and peripheral edema can be helpful with further assessing and risk stratifying these patients. What about diagnostic testing? It's important to assess renal and liver function for our original assessment. So complete metabolic panel can help provide us with all of that in addition to electrolytes. CBC can tell us about anemia, which can be very critical in somebody that's developing heart failure symptoms. Lipid panel and A1C can be a part of a greater workup for vascular-related risk and risk reduction. Thyroid, HIV all have specific factors that can lead to or worsen heart failure, and as such is it critical. BNP or NT-proBNP can be helpful to assessing heart failure and risk stratifying these patients. And follow-up BNP can be very helpful, plus some other testing. ECG can be helpful as it can also talk about ischemic and other related etiologies such as arrhythmias. BNP for the at-risk can give us ideas. For diagnosis can be very helpful, and overall for long-term management and risk stratification. Some of the factors that affect your BNP, which we should be aware of: obesity, advancing age, anemia and renal failure. What about imaging? Echo can be very helpful to both assessing the overall ejection fraction, diastolic dysfunction, and valvular-related diseases. MRI can further risk stratify for etiologies that maybe we couldn't find a reason for, such as amyloid, sarcoid, myocarditis, or others. Stress imaging can be helpful for ischemic and other assessments. Coronary angiography for vascular assessment. So we got the patient that we suspect for heart failure. We take their clinical histories, we do an exam, we get ECGs and labs, usually plus BNP or NT-proBNP. If we still have a high index of suspicion or we think heart failure is likely, we obtain a transthoracic echo. And then we subdivide these patients to heart failure with reduced, mild reduced, and preserved ejection fraction, and then try to treat them to better their symptoms, their overall prognosis, and try to risk modify their overall concomitant disease risk factors. So for HFpEF, there are a couple of risk scores that can help push towards whether HFpEF is a player factor for patients with dyspnea on exertion or other heart failure symptoms. To me, this is a little bit more difficult, and I don't utilize it as much. But similarly, this risk score can be utilized. The remaining section will focus on pathophysiology and management. Neurohormonal modulation is really essential. Acute neurohormonal activation is a coordinated response to restore cardiovascular hemostasis in a short term. It's by preserving cardiac output, increasing salt and water retention to increase preload for a Starling effect, increasing sympathetic nervous system activity, which increases heart rate and contractility, and increasing vascular resistance and critical organ blood flow. While it works great acutely, long-term it leads to more problems. Sustained neurohormonal activation drives the progression of heart failure. The deleterious effect exerted on the circulation and the myocardium. Increased preload creates volume overload and pulmonary congestion, leading to a lot of the symptoms we observe in heart failure patients. Sympathetic nervous system activation leads to tachycardia, increasing myocardial demand, limits diastolic filling. Vasoconstriction leads to increased afterload, impaired ejection fraction, and beta receptor dysregulation, which we see so commonly. We've all seen this, but we're talking about concentric versus eccentric remodeling. This is a great chart or diagram to look at heart failure. The Lind-Stevenson diagram, which came out in 2003, looks at hypoperfused versus not state and congestion versus not state. So when you look at no hypoperfusion and not congestion, you get warm and dry. The patients you see in clinic, which hopefully we're talking about the management and how to get them on optimized guideline-determined medical therapies. The not hypoperfused but congested, the warm and wet, are the patients we might see in the emergency department, sometimes in the clinic, sometimes as an admitted patient on the floor. Then we have the hypoperfusion state, and I'm going to skip over this a little bit, but these are patients that are going into cardiogenic shock, or we need to plan for advanced or next step therapies. We'll look at neurohormonal interventions to vasodilate or decrease afterload, block angiotensin II, block aldosterone, block beta receptors to permit their upregulation. This leads to the end of part 1. Once again, thank you for joining us, and hopefully you'll join us for part 2. Take care.